Hello and welcome to 5 CEI line questions answered post-exposure prophylaxis. My name is Tara Melfi, Program Coordinator for the Clinical Education Initiative, HIV Primary Care and Prevention Center of Excellence, or HIV COE. Today, I'm joined by Dr. Antonio E. Urbina, Medical Director for the Mount Sinai Institute for Advanced Medicine, Downtown Clinic, as well as the Medical Director for the Clinical Education Initiative, HIV COE. Thanks so much for taking the time to join me today, Dr. Urbina. How are you?
I'm doing pretty good, hanging in there. How are you?
You know, hanging in there, working from home. So, great. So today we're just gonna go over some of the questions asked via the CEI line.
Right.
So just as some background to everyone, the CEI line is a resource that CEI offers to clinicians in New York State to discuss HIV, PEP, PrEP, HCV, sexual health, and drug user health patient management. And for HIV inquiries, you would press 1. And this line is also open for COVID-19 and HIV inquiries that would be answered by yourself, Dr. Urbina.
Right.
Great. So just as some background for that, and due to a high volume of PEP-related inquiries that we've received, we thought it'd be a good idea to kind of share some of those answers with everyone so they would have it in a quick and easy way. So that's great that we're going to do that. So I'm going to go for the first question.
Mm-hmm.
Question 1, a cisgender female was put on PEP for mucosal exposure to HIV. She is on day 4 of Truvada and Icentris and is now experiencing nausea. So should they switch the Icentris to Tivicay? Are there other medication options to put the patient on to stop the nausea?
Great. All right, Tara, so thank you so much. Yeah, so I do recall receiving this question. So one thing we have to acknowledge really is that the current regimens for PEP, be they Truvada Icentris or Truvada Tivicay, are extremely well tolerated. Remember that we give these medications to patients living with HIV for decades. So really just being on these medications for a month is really not that big a deal. So oftentimes patients may have these startup symptoms. They may have a little bit of nausea. They may have a little bit of abdominal pain, gastrointestinal discomfort, but these typically go away within days. So again, really the first thing that we really try to do is just kind of counsel patients that these are just startup symptoms, that they tend to go away. But before we make any switches, really what we try to do is to start patient on antiemetics or drugs to help them with their nausea. So a couple of those can be, like, one drug is Reglan, so that can be dosed prior to the dosing of their PEP medications. Another one is Zofran, that can be given up to 3 times a day. So that's kind of the first advice that I would give to the caller for their patient would be to really try to walk these patients through their symptoms, let them know that they're going to be there only for a couple of days, but that the next step is really kind of to prescribe an antiemetic. So if you try both of these things and the patient still continues to complain of like nausea, then one can try switching the PEP medication. So I think Icentris has a low rate of nausea, less than 3%, but Tivicay has an even lower rate of nausea, maybe less than 1%. So if the symptoms persisted, I would consider switching the patient from Icentris to Tivicay. But the caveat to that is this, is that we know that Tivicay, also called dolutegravir, there has been an association with neural tube defects if it's given around the time of conception. So I would really want to counsel this patient that if we do switch to Tivicay, that we do really practice effective birth control, contraception, really to mitigate this risk.
Great, thank you. Our next question, a cisgender female had an occupational exposure to HIV 72 hours ago while performing a dental implant. Patient was taken to the hospital on a Saturday, but didn't get their PEP until Monday. So should this patient be able to be on PrEP for the full 28 days, even though it was given to them over 72 hours after their exposure?
Okay, all right. Yeah, so we get this one again. So this is an occupational exposure. So a dentist that was performing a procedure, and then with her instrument, then had some type of percutaneous injury or break through the skin. So this would be an indication where PEP would be indicated. And really, ideally, what's important for us as providers is that really PEP should be given as soon as possible after the exposure. So we talk about these golden 2 hours. Really, that's ideally when it should be given. But really, effectiveness really starts to wane if PEP is dispensed after 72 hours. So in this case, the patient did have the exposure. I mean, they did the right thing. They presented to a healthcare facility. However, the patient had already waited 72 hours, and then they were not prescribed PEP until 48 hours after. So they were well beyond that 72-hour window. However, at this point, the patient was already dispensed PEP after 72 hours. So kind of a shared decision was made with the patient to continue her on the full 28-day course with close monitoring and follow-up. So why it's important that we have close monitoring is that if a patient has been started on PEP after 72 hours, there's the potential that they may have acquired HIV. So they're on these medications now, not for prophylaxis, but rather for treatment. So if at the end of the month, you really want to be careful, because if they are infected with HIV and you stop their medications, then, and if you don't monitor them, then their viral loads can come up and they could be lost to follow-up. So again, in this case, really the important things to stress is that PEP should be given within 2 hours. It's most effective if it's given within 72 hours, and really exposures that occur after 72 hours, really PEP is not indicated. But in this case, sometimes what we'll see is that although it was delayed, patient was started. So we kind of weighed the risk benefits and made a shared decision to continue this patient on her PEP medications with very close monitoring, meaning that we're going to do a repeat antibody test at week 4, and then also at week 12.
Okay, great. Thank you so much for elaborating on that. Our next question is, what is the protocol for testing of the source patient in the context of an occupational exposure?
Okay, so occupational exposure, and these guidelines are from the New York State Department of Health, PEP guidelines. So for this call, I kind of walked the caller through what the guidelines recommend. So if a healthcare worker or some other worker has been exposed to HIV through either a needle stick injury or some sharps, and if the source of that exposure is available for testing, then it is important that we try to determine the HIV status of that source. Now, if the source patient is unavailable, or if they refuse HIV testing, then we have to assume that that source patient may have HIV, and that we then dispense PEP. But one other important caveat to the exposed worker is that we want to, in addition to doing antibody testing to rule out chronic HIV infection of the source patient, if the source patient has had any recent exposure to HIV, or if that person has had signs or symptoms of acute HIV infection, which means fever, myalgias, swollen lymph glands within the last 6 weeks, or any recent high-risk exposure within the last 4 weeks, that in addition to the antibody testing, that one would also want to do viral load testing on that source patient to rule out very early HIV infection. So that's important because we would only interrupt or discontinue PEP in the exposed person if both the viral load and the antibody test were negative. Now, we also reviewed with the caller, part of some of the guidance from the New York State guidelines is that we still have to get consent from the source patient to obtain HIV testing, but we just need oral consent. We don't need formal written consent. And in those rare cases where the source patient either doesn't have capacity or is deceased, that New York State law allows us to obtain anonymous testing on that source patient to help us determine how best to manage PEP in the exposed worker.
Great, thank you. Our next question that we have here, our next question is, there was an ocular exposure from gastric content from a neonate of unknown HIV status with a mother of unknown HIV serostatus. What are the next steps in terms of PEP and the issues that the exposed individual may have in terms of risk of this specific exposure?
Right, right. So again, what we know about infectious body fluids is that, typically, blood, seminal, cervical vaginal fluids, and also other types of fluids. So for example, fluids from the pleura, fluids from the joints, those are potentially infectious. Now, the fluids that are not infectious are saliva, sweat, tears, urine, fecal material. And also gastric contents are not considered infectious. However, if the gastric content or any of these other non-infectious fluids, for example, are blood tinged, then they may potentially be infectious and lead to transmission. Ocular exposure, so again, exposure to the mucosal lining of the eyes is a potential source for transmission. It is exceedingly rare though, and in the very few cases of documented transmission to the eyes, there was copious amounts of blood. So in this instance, one, the source of the fluid was not infectious. However, the exposure type, which is exposure to the mucosal surface of the eyes, was. Because both of these statements were not yes, then PEP is not indicated. So again, this was a low-risk exposure with non-infectious fluid. So PEP was not indicated, and that's what we advised the caller. However, whether or not you dispense PEP, you still want to continue with monitoring for HIV status and also monitoring for other diseases such as hepatitis B and hepatitis C, both on the source, the neonate, and on the exposed. So again, regardless, you want to perform baseline HIV, hepatitis B, and hepatitis C testing on the exposed with repeat testing, I advised, in 1 month.
Okay, great, thank you. And our last question that we have here is, a patient had been exposed by a finger stick. It is now started on PEP. The patient is pregnant and has a due date in 2 months from now. Should she be advised to have a C-section or vaginal birth?
Right, okay. So again, this is a woman that's in the 3rd trimester and has had a finger stick exposure, potentially infectious fluid. So again, PEP is highly efficacious if started within 72 hours in really containing HIV virions and preventing systemic infection. So again, remember, PEP is only a month. So really a C-section would not be indicated. Really the only indications for a C-section in a pregnant woman would be if a pregnant woman was already living with HIV and if she was not virologically controlled in the 3rd trimester. Here, we're dealing with just a potential exposure. Because PEP would be started relatively soon, we would expect that PEP would abort this infection and that there would not be any risk for mother-to-child transmission. So in this case, the exposed patient should continue on PEP and she would be able to deliver vaginally. Because this is a high-risk scenario, I also recommended to the caller that we would repeat viral load testing in the woman just to rule out any potential for a breakthrough acute HIV infection, which in the setting of PEP would be highly unlikely.
Great, thank you so much. And just to wrap up this video, just want to mention the clinical guidelines program where all of this guidance is coming from. We have on the website currently PEP for non-occupational exposure, as well as occupational exposure, PEP for victims of sexual assault. And I know, Dr. Urbina, you are currently working with a team on PEP for children beyond the perinatal period. It's currently under review, is that correct?
Yep, that is correct. So hopefully we'll get, and the plans for the new clinical guidelines for PEP is to really consolidate all of these together into one document. So that is currently under review, and we're hopeful that that will be available soon. But yep.
Yeah, great. Thank you so much for joining me today to explain kind of real life questions that clinicians are having in New York State. I think this would be very helpful for people to know. And again, if anyone would like to call the CEI line, if you are a clinician in New York State and you have a question pertaining to specifically HIV, Dr. Urbina also answers questions on PEP and PrEP. You can call the CEI line at 1-866-637-2342, and you can press 1 for the HIV line. And I will dispatch the information to Dr. Urbina. Great. So I'd like to thank you for joining me today. I really appreciate you doing this with us today.
Awesome. That's great. Yeah. And just want to really encourage people, all healthcare workers out there to really call the CEI line for any assistance with HIV, PEP, and PrEP. We also have sexual health, HCV, drug user health assistance. So again, thank you so much for watching this. And everyone stay safe and stay strong.
Great. Thank you so much.